Hello, everyone. I'm Todd Didier, Communications Director at the Primary Care Collaborative, a national organization that convenes stakeholders from across the healthcare landscape that are committed to improving the nation's health by strengthening primary care. I'm thrilled to welcome you to today's discussion on how we can simplify value-based care. Today's webinar kicks off a PCC initiative focused on lowering the administrative burden for primary care. We want to hear your best ideas. Over the next few weeks, please look out for a survey from the PCC, and another webinar later this year will focus specifically on technology and administrative burden. Just a few housekeeping items before we get started. First, for those who might not know, PCC will be hosting a conference on June 4th in Washington, D.C. June 4th and 5th in Washington, D.C. The event will bring together leading voices from across the healthcare landscape to discuss scalable, pragmatic solutions that improve our nation's health by strengthening high-quality, whole-person primary care. We have a fantastic lineup and some exciting sessions, including a showcase of innovative approaches that some organizations have already put in place to strengthen primary care. I hope you can join us, and we're thrilled to offer a 10% discount to webinar attendees who register in the next week. Just use the code APRWeb2025, which you see at the bottom of your screen. Next, I'd like to remind folks that this session, like all PCC webinars, is being recorded. The recording and slides will be posted on our website, thepcc.org, within 48 hours. You can also find all of PCC's previous webinars on our website. We'll be taking questions using Zoom's Q&A tool at the bottom, which is usually found at the bottom of the screen. Panelists will answer questions at the end of the webinar, but feel free to send questions throughout the entire presentation. Chat has been disabled for viewers, but as you've already seen, we will be dropping links to relevant resources in there throughout the conversation. Finally, the PCC is committed to delivering high-quality webinars exploring important topics to the primary care community. We'd appreciate if you took a minute or two after the webinar to fill out the post-webinar survey so that we can ensure we're meeting that standard. And before we kick off, I'd also like to thank the Commonwealth Fund and Arnold Ventures, whose ongoing support has helped make this webinar possible. Now, as I mentioned earlier, this webinar is just a part of a broader initiative that the PCC has launched to explore how we can make value-based care simpler for primary care. Too often, value-based care gets wrapped up in specific structures or measures instead of what the focus should be, improving the health of patients. That's why we're thrilled to host today's conversation with a fantastic lineup, which is the beginning of efforts to reimagine what value-based care looks like for primary care. To kick us off, I'm thrilled to introduce our first presenter and the moderator of today's discussion, Anne O'Malley. Dr. O'Malley serves as a senior fellow at Mathematica and is a nationally recognized expert in primary care services research. She'll share some of her research findings before convening today's panel. Anne, thank you so much for joining us for today's conversation.
Thanks, Todd. I'm really happy to be here. I work at Mathematica in our DC office, and we spend a lot of time evaluating primary care models, federal as well as state. But today, to kick off this session, I'm going to just present some findings from a group of providers, primary care practitioners who've never been in a value-based payment primary care model, because we want to hear about, what is it about these models that's keeping them from joining? We know that most of the more traditional primary care practitioners in the country are not joining these models. Next slide. I'd like to just acknowledge the Commonwealth Fund for funding the study, as well as my co-authors, Cindy Alvarez, Rumin Sarwar, and Jean Rich. And the contents of today's presentation are solely our responsibilities and do not reflect the views of Mathematica or the Department of Health and Human Services. Next slide, please. So let's just start with a kind of a broad definition of value-based care. And I really like the way Todd introduced the topic. It's, let's we often get stuck in some of the structures and the way things are implemented as opposed to what the actual goal is. And with value-based care, this is the definition CMS puts forward. It is healthcare that is designed to focus on the quality of care, provider performance, and the patient experience. The value in value-based care refers to what an individual values most. Um, and in these models, you are not just getting payment from traditional fee-for-service. They're obviously enhanced and other types of payments, and there are attempts to tie payments to outcomes. Next slide. So for our study for the Commonwealth Fund, the motivation was to, given all the numerous models that are out there for primary care, why aren't more of the primary care practitioners participating in them? So we wanted to know, what barriers do frontline PCPs face to participation, and what do they and some other experts in the field see as potential solutions to overcoming those barriers? So this was a qualitative study, a total of 29 participants, 12 of whom were primary care experts with whom we did key informant interviews. And then there were another 17 frontline PCPs with no prior participation in a primary care VBP model. Some of these worked in health systems that were part of ACO, so they did have some exposure to ACOs. Next slide, please. And just to get to our results, the barriers fell into three large buckets. And I will note that the PCPs felt that the primary care value-based payment model's goals are very laudable, but their enthusiasm was tempered by these challenges in financial, not surprising, performance measures, and the primary care physician workforce challenges. And I will say that administrative burden touches on each of these. Next slide, please. So first, financial challenges. Bottom line, the participants wanted to know before they join a model, is the juice worth the squeeze? So, there's a fair amount that's required in a lot of the value-based payment models that are federal and state run, in terms of not just changing care delivery, but also reporting in various ways. And so it was a concern to the to the providers. So one of the challenges that they identified, and this echoes what we've heard in our evaluations of national VBP models, is that the lack of meaningful participation by commercial payers in CMS models results in inadequate funds for practice change and reporting requirements. So participants would like to see the revenue from collaborating payers better reflect the time and staff needed to change care delivery. And they really would like to see more upfront payments. Secondly, some of our participants that were in health systems who were also in ACOs noted that they didn't see some of those ACO savings trickling down to the frontline primary care practices. And they were concerned that these other primary care models, that may be a concern. And so they would like to see some kind of commitment for health systems to send, the model money down to the front line for them to deliver on their requirements. And third, it's hard to transform care or reduce expenditures without changes incentives across the entire health system. So there's clearly a need, and many people have written about this and talked about it, to fix distorted payment rates under the fee-for-service. Next slide. The second bucket, performance measures, was something they talked a lot about. They'd like to see them be less onerous and more relevant. So first, primary care practitioners noted that some of the current quality measures are overly simplistic, and they impeded their ability to take care of more complicated patients for whom they may be less relevant. So they'd like to see more meaningful quality measures swapped in, particularly things that get at patient access and continuity of care with a trusted PCP. And they'd like to, if they have to be measured, they think it's important to ask the patients, were your goals met? Secondly, there's poor alignment on both the requirements and the quality measures across payers, which really contributes to the administrative burden that these participants were worried about. So they'd like to see more alignment on those fronts. And then thirdly, as I'm sure most people have heard about, there is a lot of documentation, busy work that PCPs have to do to make their health systems and other entities happy around HCC risk scores. And they were very concerned that this really doesn't add anything clinically to their management of patient and distracts them from taking care of patients. So they would like to see less gaming of HCC scores that are currently relevant to Medicare Advantage and some health systems in ACOs. Next slide. Finally, we'd be remiss if we didn't mention the primary care physician workforce shortage, which the participants all raised, and basically said, you know, the PCP's heavy administrative burdens and inadequate supports contribute to and perpetuate this shortage of the primary care physicians and their staff, as well as their bandwidth to participate in these models. So they felt very strongly that we need to address the underlying causes of PCP burnout, including administrative burden and other challenges to pursuing a career in primary care. Next slide. So that's it for me. If you want more information on this study, there's a lot more details available at that link on the slide. All right, great. Thank you. So now I'm going to introduce Rebecca. Rebecca Whitaker is a research director with the Duke Margolis Institute for Health Policy, focused on state and regional healthcare transformation, with a particular emphasis on North Carolina care delivery and payment reform activities. Prior to joining Duke Margolis, Dr. Whitaker served as Director of Health Policy and Governmental Affairs at the North Carolina Community Health Center Association, where she guided North Carolina health centers through large-scale payment and care delivery reforms. Welcome, Rebecca. Next, I'd like to introduce Dr. Tom Roth. Tom Roth, MD, is the President and CEO of Community Care of North Carolina, CCNC. And CCNC supports the primary care delivery system by providing practice support and care management services using targeted analytics and innovative practice-based tools. Dr. Roth is a practicing family physician and has cared for patients for over 20 years in Almonte and Caswell counties in North Carolina. And finally, I'd like to introduce Greg Moon. Since 2022, Greg Moon has served as the Vice President of Healthcare Strategy, Planning, and Performance at Blue Cross Blue Shield of North Carolina. With a deep, multi-perspective experience in payer, provider, and technology settings, he is committed to the digitization of healthcare to improve care quality and health outcomes, to enhance patient and provider experiences, and to deliver higher quality care. So welcome all. Thanks for joining. To kick us off, Rebecca, I was hoping that you could give us some background on the North Carolina State Transformation Collaborative, please.
Sure, and thanks, Anne, and thanks for the opportunity to join you all today. The North Carolina State Transformation Collaborative, or STC, is part of a broader public-private initiative of the Healthcare Payment, Learning, and Action Network, or the LAN, and the Centers for Medicare and Medicaid Services, and really designed to promote value-based and whole-person care to advance health for all through multi-stakeholder partnerships. In addition to North Carolina, there are 3 other states who are participating in this initiative: Arkansas, California, and Colorado. The efforts in North Carolina have been supported by the North Carolina Department of Health and Human Services and the North Carolina Medicaid Agency. And sitting at Duke Margolis in my role, we are serving as the neutral convener for this initiative. And that's really a key part of our Institute's efforts to generate and translate evidence to provide practical policy guidance that really can advance health equity and the value of healthcare. I do want to acknowledge kind of the context surrounding this initiative in North Carolina and provide some rationale for why North Carolina was selected to participate in the broader State Transformation Collaborative initiative. North Carolina really is recognized as a leading national model for how to shift from paying for healthcare services to investing in health. The state over the past few years has implemented Medicaid managed care and Medicaid transformation with an emphasis again on whole person care and well-coordinated systems of care, launched Medicaid expansion that has upwards of 630,000 new folks enrolled in the program. As well as kind of implemented the landmark Healthy Opportunities pilots, which are using Medicaid dollars to address drivers of health. And we see similar investments in value-based care and whole person care in the commercial context in our state as well. So with all of these different initiatives going on, North Carolina leaders needed help kind of streamlining how these health reform programs are being implemented in order to support kind of the healthcare and social service systems capacity to provide that whole person care, reduce the time that providers were spending on administrative tasks so they could focus more on caring for patients, and certainly measuring the state's progress toward its health reform goals. So as you were noting, Anne, in your presentation, multi-stakeholder alignment on the components of payment models like performance measurement and data sharing can make it easier for provider organizations to adopt value-based payment arrangements. But it's certainly challenging, to get to agreement on some of those practical steps to achieve multi-stakeholder alignment, especially when stakeholders may have varying approaches for how they kind of achieve their own organizational goals. So this is really where the North Carolina State Transformation Collaborative comes in. It was launched in February of 2023 to identify strategies that could support North Carolina-based investments, as well as kind of recognizing the broader national health reform initiatives to ensure that we can achieve intended goals. And, again, kind of these transformation efforts can exist in silos, but really can accomplish more when they're brought together. And so bridging those silos, encouraging collaboration across stakeholders that may not typically interact. So we have been convening stakeholders to identify shared goals to improve health and well-being in our state. Some of the key challenges and practical solutions, which I think very much align with some of the ones that you heard in your research as well, and in terms of, how can the healthcare system work toward achieving some of these shared goals. We've convened a broad variety of stakeholders over the past few years, including health system representatives, healthcare providers, variety of health plans spanning Medicaid, commercial, Medicare Advantage, in addition to CMS. Clinically integrated networks, subject matter experts, community-based organizations, and state government entities like North Carolina Medicaid and our State Health Information Exchange Authority. We've organized this effort through kind of a series of strategic leadership and technical working groups to make progress, and really view this as an opportunity to facilitate alignment and collaboration on key payment and delivery system reforms in the long run, including, focusing on national reform efforts as well. So we think it's a process that hopefully, mirrors things that some states have used, and hopefully other states could find other or similar strategies to help advance healthcare transformation and improve health outcomes.
That's really helpful, Rebecca. Thank you. So Tom and Greg, could each of you tell us a bit about what motivated CCNC and Blue Shield North Carolina to participate in the State Transformation Collaborative?
Sure. And yeah, Greg, I'll go first.
Good.
So this is really a no-brainer for us. And you think about, one of the administrative burdens really of doing value-based care for primary care practices is it's really hard to get everybody, the right people at the table in one room. So it's incredibly rare. We had CMS leadership, state leadership, health plan leadership across multiple payers, and provider leadership. We represent a lot of independent practices across the state. In fact, 450 independent practices, big and small, all sorts of different capabilities. And they're really getting crushed by the administrative complexity of multiple programs. So it was an opportunity to really work on some of the things that Anne, you presented around measure alignment and what can we do as sort of a public utility to help all of these practices. And reduce some of the administrative complexity and get folks back to what we want, which is practice transformation and improved health outcomes for patients. So that was our story. Greg, what about you?
Thanks, Todd.
Pretty similar. First of all, I just want to express appreciation to Dr. Whitaker and the group that she has convened through the collaborative. It's really helping the state align around model design, around key enabler and technologies, and what data sets we need to succeed. The reason that we joined, similarly, we wanted to be part of the ecosystem discussion. This is a set of ecosystem problems that we're facing, and we need ecosystem solutions. And the thing that gets a little bit lost about the conversation about value-based care, and we usually are talking about the blocking and tackling and everything to make the program go, is really a paradigm that establishes a collaborative approach to these problems. If we didn't have value-based care, we would be left with payers and providers arguing about fee schedules and managed care processes, et cetera. So philosophically, that's why we wanted to join. Tactically, just having an ear to the ground to what everybody is thinking is incredibly valuable. We can be kind of, navel gazing in our own sort of world of, we have our models, we're working with our given set of providers in the network. But, it might not occur to us, wait a second, those providers, they have, multi-dimensional relationships around value, and they have variation across that. And, to hear in the early days of being part of the collaborative that, the quality measures were wildly variable, you could just think of the added administrative burden from that. So just the insights we get from the group are very, very valuable.
Mm-hmm. Great. Thank you. So you've alluded to this a bit, but I would ask if you could each maybe tell us how have you been able to identify shared goals and priorities for lowering the administrative burden on primary care? And what are those shared goals and priorities? Whoever wants to go first, feel free.
Becca, do you want to start?
Sure, I'm happy to start. Yeah, and I think that's a real critical question and starting point for all of these discussions. I'll mention, a lot of our work with the State Transformation Collaborative was guided by a framework, a multi-payer framework that some of my colleagues at Duke Margolis put out several years ago. And we've kind of used that to kind of operationalize that framework through the State Transformation Collaborative. And a key part of that is identifying those shared goals. And in order to kind of really make progress, motivate support, and also allow for that impact tracking and implementation and evaluation. So the specific goals that the stakeholders participating in the State Transformation Collaborative identified were addressing health disparities, improving population health, reducing healthcare costs, relieving provider burden, and enhancing the patient experience. So these are broader than certainly just lowering administrative burden, but I think the goals are really interrelated and kind of mutually reinforcing. Like, certainly addressing health disparities also means ensuring sustainability of kind of small, rural, and underserved practices as well. And so these things go hand in hand. And those are really our guideposts for this work. And we try and track back constantly to, how are these alignment opportunities advancing those goals? And we're kind of focused. Our objective is really to establish high quality and whole person care statewide. So better health, more equitable, comprehensive healthcare for individuals, families, and communities with a focus on primary care.
Rebecca, if I could, before we go to the other panelists, could you say a little more about the piece on relieving provider burden and maybe give examples if you have any?
Yeah, and so this being one of the key goals that the group identified as critical to enabling a shift and success under value-based arrangements. I think some of the pain points, and happy to talk more about these later too, that came up most frequently, very much align with what you were outlining in your presentation, Anne, and what Tom and Greg were talking about as well, with respect to challenges with performance measurement, given the number of measures and sort of variation in the measurement process, so the implementation of those measures. Thinking about challenges related to data and moving data and having access to timely data. And then finally, the work being done in the state and nationally to collect data on health-related social needs, for example, and how that may vary both within and across organizations, and so how that may be contributing to some additional burden. So those were
Great.
some of the specific areas that folks identified, but I think the overall goal being, in recognition of workforce challenges, in recognition of just kind of the overburdened experience of providing primary care.
Great. That's super. Thanks, Rebecca.
I
Greg?
was just going to jump
Yeah.
in and say, for us as a provider group, the low-hanging fruit that we were hoping for is really around measure alignment and reporting, simplifying the reporting mechanism. So around measure alignment, we've got value-based contracts across, 5 different Medicaid managed care plans, Medicare Advantage, Medicare, Blue Cross Blue Shield with Greg's organization. So we've got multiple measure sets, multiple reporting schedules, and then we've got the problem. And for small practices, we're still on lots of different electronic health records. We actually have 52 different electronic health records. So we, by hook or by crook, we pull out A1Cs and blood pressures and other colon cancer screening, Pap smears, and report to the various payers. And so so this is not even what's happening in the workflow of the practice, but just as a primary care enabler or CIN, what we do to report. So we were hoping for, with all the players at the table, to really try to get to some measure alignment and agreement on the key measures across multiple plans on the pediatric side and adult side. And then on the reporting side, just trying to standardize. So if we're working in Medicaid with 5 different plans, there's just little differences and nuances which don't seem like a big deal, but create incredible, I guess, burden for in our role, trying to report clean data so that Greg can have it HEDIS certified and all of that. So we saw that as a huge potential win, low-hanging fruit. And I think one of the things I just want to mention about the collaborative is one of the key things is that it was the leadership there. So the Secretary of Health and Human Services for North Carolina was there and basically laid down the gauntlet and kind of said, don't come out of the room until you all agree and can kind of move this forward. And so again, that leadership was really critical in the process.
Yeah. For identifying our priorities, obviously for strategic objectives, the same North Star as all you, which is the quintuple aim. From a tactical standpoint, how do we make sure these models are sustainable, feasible, and administratively as low burden as possible? The collaborative was a great channel for understanding those needs. We also have a lot of one-on-one interactions with our providers within value arrangements. We have a team dedicated to meeting with folks, going over the reporting, looking for opportunities. But it's a two-way street. Where we definitely hear the pain points that come through from this, and we synthesize across those conversations, and that's actually what kind of led to us moving from what we called our Blue Premier 1.0 model to our Blue Premier 2.0 model, which was really predicated on in large part by the feedback that we got from providers. So I think the most important way is keeping the ear to the ground and having the dialogues around these things and constantly looking for opportunities to make these things more palatable, sustainable, and feasible.
Mm-hmm. Great, thank you. So if we think about, what has helped to move, what's helped most to move from identifying these problems to finding solutions for a particular barrier or pain point. Tom, you mentioned, the strong leadership in the state, North Carolina, around at their Department of Health and Human Services. What else? I don't know how the others feel about that particular question or that particular facilitator, or other things you want to mention that you think really make a big difference.
I'll just put a plug in that the group was really focused on feasibility and not solving world hunger, but what can we do now together during these sort of performance cycles and contracting cycles with all the plans in the room. And so, and Rebecca, you might want to expand on this, but we really focused on, measure alignment, I think reporting simplicity, and then health equity data. How can we actually refine the health equity data as a kind of consortium of stakeholders so that we can actually really drill down on healthcare disparities and really look at population health issues as a group.
Yeah, I don't have much to add, save for, those common voices, and the strength of those voices is very motivating for all the parties. And we try to reflect it as much as possible in our design and our engagements.
Yeah, and I think my answer might be a bit strategic and also tactical, in that I think, Tom, to your point, the kind of intensive stakeholder engagement that goes on to sort of find that common ground, both through convenings, but also kind of these individual one-on-one calls that we do with folks to sort of gut check where things are heading and allow folks to push back if maybe, it wasn't as easy to do that in a group setting, for example. But I think the strategy that we've taken is really trying to get more granular over time. So kind of starting with those shared goals, and then how do we want to work toward those goals? Kind of what are those key strategic areas, aligning on performance measures, improving data sharing, and enhancing health disparities data, and then going a level deeper, like, okay, what are the biggest pain points within those, and what are some potential solutions that we can be working toward? And I think feasibility is really, really key there. I would say, certainly taking things off the table as well if we didn't have strong consensus across groups. And that was a way of kind of continuing to build momentum. But I think, ensuring trust when people raise things like this is going to be a non-starter for us, that we could take that off the table and find other areas of common ground. And then I think I would say, not, to Tom's point on not trying to solve world hunger, but really picking kind of a few key foundational elements and areas where we thought we could make progress, and doubling down, not, instead of coming up with a new measure set, for example, we focused instead on how are those measures being implemented and where can we identify opportunities for alignment in the kind of the data collection and reporting on those measures. So not the measures themselves, but the process of reporting on those. And I think another piece I'd highlight there is, and I touched on this earlier, but not trying to come up with like bespoke models or opportunities in North Carolina, but leveraging initiatives that were underway in the state, but also priorities outlined by both our kind of state leadership and national leadership. And so how can we work toward those things together rather than kind of creating new reform efforts that folks were going to have to manage. And then finally, I think I would highlight kind of being responsive to where organizations are in the range of capabilities across organizations. I'll give one example on our data sharing alignment opportunity, where we really, recognize that some organizations are like ready to get on the highway and drive 70 miles an hour and do bulk fire for exchanging data. And then other organizations like maybe running on the frontage roads for a while and kind of want support for that work and one day kind of merge onto the highway. And so trying to identify, how can we standardize supplemental data submissions across payers so that provider organizations aren't having to tweak data reports in sort of non-meaningful ways to submit to payers, as well as how can we leverage opportunities like the NCQA bulk fire coalition to help folks kind of learn how to improve data quality and leverage that for bulk fire data transmission. So just wanted to kind of give a nod to how these things are very overlapping, but also intended to be responsive to kind of the range of organizations.
Great. So doing this, even focusing on things that are feasible, requires a lot of resources. And how do you think about the need for resources to support these ongoing processes to align?
I can just make a comment. I mean, you think about it. So we could probably say we're in an environment where federal policy, and I think in our state, North Carolina, it's sort of unpredictable right now. There's sort of a lot of changes and other things, but it's really not all that expensive. I don't know how much it costs you all, Rebecca, and all that, but to convene is so much less expensive than trying to drive through a new program, a new policy, and put cash out the door. So I think in a way, what, at the end of my message to the rest of the folks on the webinar is it's really about finding a convener in your state that's local, bring in some federal people or others, but that doesn't take additional money. It takes probably $1,000, and I'm sure lots of work went into it, but it actually is kind of feasible for other states to do what we did.
Oh, great point.
Yeah, I'll maybe take the question in a slightly different direction. This is a little bit of a chicken and egg argument, but if you can reduce silly manual work and through automation and digitization, it frees up people to focus on the stuff that's more important. So a big focus for us is really thinking about how to eliminate things like flat file, manually prepared quality things and set up pipes and data exchanges. Dr. Whitaker was referring to gather that individually. So it's I think we need to use it is a time of scarcity, and we need to use our resources as maximally efficiently as possible.
And how do you,
sorry.
Go ahead, Rebecca, please.
I was going to say the only thing I would add there is certainly to Tom's point, the importance of North Carolina Medicaid supporting this effort in our state has been really critical. And then to Greg's point, really, I think that's where it's useful to really peg to kind of ongoing initiatives and use cases where there may be kind of other or already existing funding flows or resources or things that you could leverage for the work as well. So.
Is there any kind of consensus developing around some shared platforms and assets that should be strengthened or built? You've all talked about data exchange in one way or another, and I know there's some health, NHIE and other things going on, but what can you tell us a little bit about that? What do you think the consensus, if any, is on those sharing platforms?
I can add a little something. So our group's in charge of our clinical data exchange effort. And I've really seen the tenor in the ecosystem shift over the past 2 to 3 years. It had been a lot on the provider side, understandably, a little bit of suspicion, like what are the payers going to use this data for? Are they going to use it to deny more things, et cetera?
Right.
To one where I think there's a very common recognition that these processes are overly burdensome. There's not only efficiencies to be found, but if you're getting the right insights to the right people at the right time, that has value. People, care will be better, providers will perform better under value-based care, payers will flourish. I feel the momentum building considerably. We're investing heavily in that over the next 3 to 5 years. And are hoping to partner with as many provider systems as possible, because it really takes, 2 to tango to get this to work well.
Anyone else thoughts on that?
I think, Rebecca, maybe I'll tee you up because you know a lot of it, but I think in the group, there was a huge focus on potential use cases with the HIE. And there's a lot of work going on there. But I think as it's sort of a, what would help everybody, the payers, providers, and other stakeholders, there's a lot of interest in what we can do with our HIE.
Yeah, no, that's a great tee up, Tom. And I can see that. So yeah, I think there was broad consensus in the group that, we should really be focusing efforts on leveraging the North Carolina Health Information Exchange, NC Health Connects, as a resource both for population health management, but also kind of using it, using data from the HIE and NC Health Connects for performance measurement to get to the point of, what Greg was alluding to earlier too, so that as providers are submitting data, that payers could just draw that down directly from the HIE rather than having to go to the provider organizations and ask for, supplemental data. But in order to do that, of course, the data have to be high quality and auditable from the perspective of the payers for performance measurement. So certainly a big piece there is the legwork, tied to improving data quality and kind of using the standardized data formats and things like that. That really does require financial support, technical assistance, et cetera. But building, I think our intent is to, again, build on work underway in the state in that North Carolina Medicaid and HIE have been leading in collaboration to help kind of boost that data quality and the data pipelines with providers, so that those data could be drawn out for performance measurement.
Yeah. It makes me think of something you said earlier, Tom, which I think you said there were 52 different EHRs in the state. And, so to Rebecca's point of you need really good quality data, you need it entered in a way that can be similarly kind of, uploaded, and an HIE can then, the measures can be processed. And tell us a little bit about that. I mean, it's tough to get vendors in some cases, to change. And do you have thoughts on how EHR vendors play a role here at all?
Yeah, got lots of thoughts on that. But yeah, so well, one thing one of my colleagues has said, I'd rather get a divorce than change EHRs again. So you have, especially small practices, under-resourced practices that are on legacy EHRs that are difficult to extract, clear data from and report it well. So I think where things are going, we're actually putting out grants to try to consolidate our EHRs, not down to 1, but down to 4. And we're trying to get some consolidation in the market, and hopefully payers and others will incentivize that. The current state, and then we can talk about future state, the current state is that we've got, we use one vendor to extract the data and sort of like organize it and parse it and normalize it. It then hands it off to a value-based care platform. So all of these ACOs and CINs and hospitals are using, there's a whole industry of value-based care platforms. They help do analytics and, take in claims data and organize it into different tools for both the practice and their workflow and the CIN and ultimately the payer. And so there's this whole kind of thing going on, but really to get out to, 90% of our members, towards 100%, we're also having practices report CPT2 codes. We're doing some manual extraction. We're doing, primary source verification where we go in with people. So there's a whole bunch of complexity and cost going into our current state. Where things are going, though, some of the EHR vendors are sort of aggregating the key quality measures in the cloud and then passing them directly to a payer, Greg's organization, or to others, and that really makes a lot more sense. And the HIE could play a role in that as well. So we really need these kind of public utilities to help extract, organize, and report data on behalf of small, rural, under-resourced practices.
Mm-hmm. Great, thank you. Well, I think we're getting to the point where we want to open this up for questions from audience and people who are attending. So any parting comments from any of you before we do that? You'll get a chance to say something else again, obviously, in response to the questions, but anything we've missed that you want to make sure you get out there before we open it up? Nope.
Yeah.
Okay, great. So, Anne, Anne Kemsky, should I just read the questions out loud that you've put in the chat here? I guess I'll do that. All right, so first question seems to be, given the pause in the HCP LAN, will North Carolina State Transformation Collaborative continue?
Yeah, it's a good question.
I think Rebecca froze. Is she frozen, or is it just me?
I think
she's
she froze for us too.
Yeah.
We had to have that once on the webinar.
I know, of course, it was going too
Of course, it's the only
smoothly.
question only she's
And,
the only one that knows
so
that.
there's a stop work order on the land right now for 90. That was poor timing, I suppose. I have an unstable internet connection, so I'm going to try and talk off camera, but can you hear me okay?
Yeah, now we can. Of course, it happens when we're talking about technology.
I know. And the irony is that I'm in the office today too. So not even my home internet. But I was just saying that there's a stop work order currently for the LAN for 90 days. But so that's kind of what that question is referring to. I think in North Carolina, we have the benefit of the support of North Carolina Medicaid. And so we are able to kind of continue the work and anticipate that our work will continue going forward. So we're excited about that.
This is a question for any of you. Have you discussed or tackled the issue of attribution, patient attribution?
Maybe that's something I can speak a little to. So the way we've approached attribution has evolved over time. When we first started that's my cat who knows how to open doors. We used a retrospective methodology, and that was dissatisfying for a number of reasons. Because you would be getting up to the sort of last minute, you'd be finding out who you would be responsible for, accountable for. So we moved to a prospective attribution methodology, which allows much more sort of clear go-get from the start. There's trade-offs with both, but it does seem to be that there's much higher preference for the prospective approach. Where things get a little bit complicated is we have primary care models as well as specialty models, and how there's a lot of logic that's behind how you divvy up who's actually ultimately accountable in those situations. So I think it's a perennial problem, but it's something that has been steadily improving from our perspective, at least.
Mm-hmm.
Can make just comments. This is a really kind of a annoyance or something that primary care practices, and it's one of the administrative burdens within value-based care. And I think just for Greg's organization, they've done a great job in sort of advancing how we approach it. Looking at the different patients that you take care of in the commercial population, most folks who should be are using primary care. That changes when you get to Medicare and to Medicaid. And to talk about Medicaid, the numbers are horrible. Like, maybe 50% of people have gone to primary care in the last year. And, so those folks are in your value-based care denominator. And what we've been dialoguing a lot about in North Carolina is that many of them should be in your denominator. They should be coming to primary care. They've got chronic conditions. Mm-hmm. There are probably some healthy folks in there that have no intention of going to your practice, but they're assigned to you and they're in your denominator. And then there are folks who maybe, I'm not sure what the right word is, but misusing the system, going to urgent care and ER and hospital with certain conditions that should be coming to primary care, and they're in your denominator. So it really is, you know, from a payer perspective, they're kind of like, I'm going to set it and forget it. They're assigned to you. You're responsible for their total cost of care and their care gaps. But when you get to a practice level, when you're really putting the, you know, the cost, the work, the sweat in to improve your panels, health outcomes, and you've got all these folks that you've been assigned that have no intention of going to see you, it can be really a struggle. So, you know, just appreciation to Greg's organization, to the others that are really trying to make this work for value-based care, because it really can be a demotivator, motivated for people.
Yeah, great point, Tom.
Yeah, that you know, a boots on the ground perspective is incredibly valuable. Conversation for another day, but another key enabler for value is going to be how do we collectively and collaboratively navigate our members through the ecosystem, and how do you do the outreach to those that are unengaged and get them engaged, and do that in a way that's you know, coordinated between the different stakeholders.
Mm-hmm.
Good opportunity for future state transformation collaborative work. Yeah.
All right, let's see. Let me make sure I pull in. Well, so another question has to do with the use of the total cost of care outcome as a measure, and I know in our study we certainly heard that primary care practitioners felt that primary care should not be held accountable for the total cost of care when most spending is coming from other sources. But are you planning to tackle that definition, total cost of care, or other measure type outcome definitions?
So curious, Greg, what you all are doing in this space. So through the STC, we have not talked about total cost of care yet, though we certainly anticipate, you know, there would be other measures that we could work on in the future. But the focus, at least initially, are on kind of two key measures where the data sharing challenges were especially prohibitive in terms of automated data sharing and kind of the burden associated with the data work there. But yeah, I'm curious if Greg or Tom have thoughts there.
Yeah, I mean, we have a philosophical tenet that you know, primary care, even though they might not have hands-on levers for everything, they have a fair amount of influence over it, and you know, it centralizes them as kind of the key quarterback. We do have situations, you know, where it's a primary care network. They don't have their own hospital system. They're obviously not getting held to account for any kind of hospital type quality measures. So there are some customization for that type of provider. The other thing is there, I think we need more tools that we use together for helping to influence the non-primary care spend. So for example, using cost, quality, and appropriateness measures to arm our primary care providers with information about, oh, okay, where would they, you know, get the highest value for that particular member to optimize referrals. So I think there's things to be done that still would kind of keep the TCOC paradigm relevant, and we can improve that situation.
One of the barriers, just to put out there, is often the tools that a provider group or primary care group needs to kind of influence and drill down on total cost of care are challenging. You know, those are some of the data feeds that are more challenging to work with, or different payers, not Greg's organization, but others, you know, sometimes have challenges with. So, you know, primary care is definitely, we can't say that we don't hugely influence total cost of care. But on the other hand, we really need the tools to be able to impact the parts that we can, and maybe not, you know, we have to partner with others to influence steerage and with specialty folks, and site of care with imaging, things like that. But one of the things we can really impact is transitional care. So folks coming out of the hospital, coming out of the ER. So good, strong care management can really bend the total cost of care piece there.
Yep. Yep.
Point.
Great. So there's another topic that we haven't touched too much on directly, but we have indirectly, which is, given the vast number of payers out there, there, there's been talk about, why can't we streamline and standardize both credentialing and contracts with payers to get rid of some of the burden that primary care and other providers face? Do you have any thoughts on that, or what's happening in your state?
I was just going to say a lot of provider groups do try to streamline credentialing, do that as a group. But what this question is probably asking is, hey, can't we all, it's the same set of information, can all the payers get together and have just like a common, med school application or college application? How about a common app across all payers?
Exactly.
I think that makes a ton of sense. And the other common thing is it's often common vendors that are doing this. So it's, all the tools are the same too.
Exactly. Yeah. And we know in other industries they've managed to do this. And so healthcare is kind of late to the party on this one. All right. So could you talk a little bit about patient participation in the collaborative?
Yeah, we haven't engaged patients directly, acknowledging the, wanting to ensure meaningful engagement of all groups. And in some of the, the data sharing conversations have been perhaps more technical in nature, but we have broadened our table, particularly around the health disparities data conversation and pulling in folks who represent different community-based organizations and different patient populations for those conversations, trying to identify some guiding principles for the collection, sharing, and use of health disparities data, and then, really talking about the experience of being screened for health-related social needs and things like that, and kind of the burden, both, we've talked a lot about burden on patients and families, but also burden on staff, and we're asking those questions. So ensuring those perspectives are at the table is really critical, and also being mindful of the spaces where we can engage folks in meaningful ways. And certainly hope to kind of expand on that in the future. So I appreciate that question. Yeah.
Well, it looks like we're kind of at time for this part of the presentation. So I want to thank you all for your very thoughtful comments and sharing your experiences. That's been great. And I'm going to turn the session back over to Todd.
Fantastic. Well, thank you all so much for that fantastic conversation and for sharing the progress that's been made under the North Carolina State Transformation Collaborative. I think it's a great starting point for how we can begin to make real progress on improving value-based approaches to primary care. I also think it was an important reminder of the challenges that we still face in making the progress that we all wish we could see. As I said at the beginning of this webinar, this is only the beginning of a broader initiative. Over the next few weeks, the PCC will be sending out surveys to the folks that attended this webinar and our broader community, and we're hoping to get your feedback and your thoughts so that it can guide our efforts to advocate for the primary care community on these issues. We also will be having another webinar later this year. We hope you can join us for that conversation. And as I mentioned, it will be heavily focused on how technology can relieve some of the challenges that we're facing. Nothing is a panacea, but anything that we can do to streamline this process and make it easier for folks is something that we should be looking into. And technology obviously plays a phenomenally important role. Finally, closing us out here, I'd just like to remind everyone one last time that we do have a conference coming up June 4th and 5th where we'll be discussing a lot of really pressing issues for the primary care community and highlighting some phenomenal approaches to care that are really making a difference in people's lives. I really hope that you can join us. We will be providing you with a discount if you register in the next week using the code at the bottom of the screen. And thank you again for joining us for today's webinar. I hope you all have a wonderful afternoon. Thanks.